All right. Good evening, everybody. Welcome to another amazing week of our Winter Endurance Sports Medicine Lecture Series with the Canadian Academy of Sport and Exercise Medicine. We'd like to take this moment to thank our sponsors for this week, PhysioWorks and MScPT. We have the amazing Brittany Vandyken presenting for pelvic issues in endurance athletes. We'd like to thank PendoPharm, MD Financial Management, and my clinic Reactivate here in Huntsville. Just want to give a couple of quick words about this week's session. If you have any questions, please put them in the Q&A section on the Zoom down at the bottom. There's a little button at the bottom that says Q&A, and it looks like two little cartoon bubbles. Click there, type your questions in there, and we'll answer them in the question and answer period at the end of each of the presentations. If for some reason we don't get to the questions that need to be answered, we will forward them to the appropriate presenter and they will have an opportunity to answer them after their presentation, either live during the lecture series tonight, or the email answers will be mailed out to all participants afterwards. Additionally, if you get a question that you're scratching your head about after the presentation, you can always email Helen Howarth, and she will put her email in the chat now. And if you have, that's if you have any questions after the fact for any of the speakers. This is going to be recorded, so everybody will get a link to the presentations done tonight tomorrow. If you have signed up for the lecture series, you will have access to the lectures for the entire lecture series. And I'm not sure, Helen can tell us when that drop dead date will be for that access. The link for the next session will be sent out to everybody tonight by the end of the presentations. So don't be worried if you don't see it in your email box just yet. So we are going to start off with the illustrious, incredible Darrell Menard for this week's first presentation. Dr. Darrell Menard is Métis, born and raised in Edmonton, Alberta. He has had a long and varied career in both sports and the Canadian Armed Forces. Persistent training and physical activity took him to the 1976 Canadian Track and Field National Athletics Championships, where he ran the 1,500 meters in 3 hours, 49 minutes, and 6 seconds. Oh, wait a second, that's 3 minutes, 49 seconds, 0.6.
I can do 3 hours now.
Yeah, that's the Canadian Armed Forces record that remains unbroken to this day. His experience in sports combined with leadership abilities made him the coach and guide runner at the 1980 Paralympic Games, where he and Jacques Pilon won a Paralympic gold medal and set a world record. He has worked extensively with athletes from multiple sports and has covered Canadian teams competing at multiple games, including the 2012 Olympics, the 2015 Para-Pan Am Games, and the 2016 Paralympic Games. So join me as I warmly welcome Dr. Darrell Menard to present this evening's first talk, The Aging Athlete.
Thanks, Rich. Can everybody hear me?
Yep.
Yes.
So I hope that the talk tonight will offer some of you something. I mean, there are maybe many of you who are in the group that includes me and this guy that's lifting these weights, but I can guarantee you that if you aren't in this group, at some day you will be. So you might pick up some tricks on how to get to this age and still be well preserved. So here we go. Uh-oh. Why are we not? You are sharing your screen. Nothing's moving. Oh, there we go. I'm not sure why the delay. I don't have any I don't have any financial interests, potential conflict of interests, or mitigating bias other than the money that you see me slipping into my jacket there on the screen. So the goal of this talk, I'm going to try to make you aware that aging athletes are physically physiologically and psychosocially different from their younger competitors. I'm going to highlight that aging athletes have some unique injury patterns and try to convince you that aging athletes have some specific training needs. So there's a guy, a legend, Jack Rabbit Johansson, who cross-country skied, for a very, very long time in his career. So why talk about this subject? Like, why would we be introducing this to you guys? So first of all, many people over the age of 40 are engaged in sports and fitness, and we want that. I mean, that's one way for them to stay mentally and physically very healthy. In my own experience clinically, what I find concerning is that there are some patients that I meet who are aging and they fear that physical activity will actually hurt them. And so, I have to spend some time trying to convince them that this is in fact not the case. When I had the privilege to go to the Olympics in London, there were 185 competitors at those games that were over the age of 40. And the oldest person there competing as an athlete was 72 years old. So even at the highest level of athletic performance, you're seeing people who you would consider to be aging athletes. Many aging athletes are seeking professional help from people like you in the audience to help them stay in the game. I want to continue to be playing tennis, even though I have a rotator cuff injury, etc. And I also think it's important to illustrate for you that aging athletes are different and have different needs from their younger opponents. And clearly this guy who's running there is different. I don't really I don't understand the getup that this guy's wearing, clearly in very cold weather, but his hands aren't going to freeze off anyway. So how good can they be? Well, this guy is named Banana George. And everything Banana George owns is this color. That's why they call him Banana George. And this is him at 93 years of age. My father just passed away last week at the age of 90. And I can assure you that my father could not have gone barefoot water skiing, holding the actual tow rope with his teeth and looked this good. Like that just wasn't going to happen. So this is quite a unique human being. And he probably could have made a lot of money doing denture grip commercials. This I've just put in. These are not, some of them are endurance, but what I wanted to point out to you was, if you look at the 100-meter times for the men and the women, both of those times for people who are over the age of 40 could conceivably win an Olympic gold medal. And if you look at the marathon for men and women, both of those times could conceivably win an Olympic gold medal. So, you are looking at people who are, potentially 20 or more years older than their opponents who are still capable of winning at that level. If you're looking at somebody else, in a different type of sport, Jaromir Jagr is a very good example. Played at the age of 45, he was still playing in the NHL, 24 seasons of professional hockey, second all-time in scoring. Even in the year 2016, 2017, that season, he still put in 46 points in the net, 5 Art Ross trophies, NHL, world, and Olympic champion. So again, you don't see even guys as talented as Mario Lemieux and Wayne Gretzky, and eventually you're going to see Ovechkin. These guys just cannot handle the load at these ages. So this is a very unique human being. When you look at the definition of aging, there are all kinds of them, but I'm going to just give you the definition based on 4 basic properties. That aging is a universal thing. So if any of you in the audience think that you are not going to age, you're already older since this talk started. So it's universal. It's also decremental. Eventually, typically past the age of 30, you start to see decremental changes in how people function and how they are built. It's progressive. It just gradually continues to actually be decremental. And most importantly, it's intrinsic. It's wired into each of us. It's not something that you can stop. And we will all age at different rates. Some people very quickly and other people very slowly, but it's still innate in our genetic build. So these are two gentlemen who, this is Alex and Pierre Harvey, two of Canada's absolute treasures in terms of endurance cross-country skiing. And you can see one is clearly older than the other, even though they were both world class. Pierre, who is on the outside, is no longer capable of competing against his son. So again, aging is inevitable. It's genetically innate. It's not a pathological process. The rate of aging is highly individual and can be influenced by things like genetics, lifestyle, and disease processes. There's a linear decline in functional reserve for most systems in your body after about the age of 30. The rate of decline from actual aging is actually really quite small. Most of the aging or things that we attribute to aging are actually attributable to disuse and not the aging process itself. So what kind of influences do lifestyle have? Well, it really can affect the aging process. And these are things, every one of you, I'm sure knows these. Smoking with microvascular disease, obesity, overloading your articular surfaces, alcohol abuse, drug abuse, poor diet with vascular disease, and inactivity. And one of the things that when I started in physical education that they were talking about, this was back in the 70s, was that someday inactivity was going to be recognized as a major risk factor to your health. And guess what? Of course, it is. And inactivity is certainly a big issue, even in the pediatric age group, but it's especially dangerous when you get older. So aging or disuse, this is a picture of Ronaldo when he was in his prime, and this is a picture of Ronaldo clearly when he isn't in his prime. So for the average person, the majority of these changes that occur are disuse, loss of physiological function, and changes in your biology. Your body is really governed by this very simple principle, the use it or lose it principle. And that is easy to say, but that's exactly really how it works. If you want to have a big bicep, you got to work on doing curls and stuff. And if you don't, or if you stop, that your biceps are going to get smaller. So it's true of all of our systems. And so clearly, that picture illustrates that Ronaldo hasn't been doing much running since he retired. And the take-home message on this is people need to move to stay healthy. And this isn't even just obviously referring to athletes. Ordinary people who don't consider themselves athletes need to move to stay healthy. So how do older and younger athletes differ? So this is a daughter and her mother out for some pole walking in the winter, and they're both getting benefits from it, but they're both different. The daughter and mother are structurally different, they're physiologically different, and they're psychosocially different. The young lady in the blue is probably investing some time in her mother because she loves her, and her mother, is working on her independence, saying, I need to stay fit so I can actually continue to live on my own and not be in a home and become in my opinion, I'm talking about her, I don't want to become a burden to my family. So there's no test at the end of this, and these are just available to you to look at, but there are definitely physiological differences that occur with aging. And the other day, our cardiology colleague mentioned one of the big issues was stiffness in the cardiovascular structures. And when I went back and looked at these again, after his talk, the majority of the changes that you see here are really related to stiffness. So that the collagen of the connective tissue in your body becomes more cross-linked and just becomes stiffer. And so that's true of your heart. You'll have a 0.8% drop in your, your maximum, your VO2 max over per year after the age of 35. And that occurs whether or not it occurs even if you're staying in top form. If you start being inactive, that number will drop faster. When your respiratory system, you can deliver less oxygen to your working musculature. Your vasculature is stiffer. Some of your vasculature disappears because of microvascular disease. Your central nervous system, there's loss of nervous tissue. So you have slower reaction times, and you have more balance issues, and you have more difficulty dealing with complex motor skills and multitasking. Connective tissues, we've already talked about how they become more cross-linked and more stable and more brittle. Remarkably, muscle biochemically remains relatively unchanged. But again, it's less compliant because of connective tissues, and you lose fast twitch fibers preferentially over slow twitch. Cartilage becomes more brittle. That's why I see so many meniscal injuries in 50 to 70-year-olds. Tendons and ligaments, exactly the same thing in terms of stiffness. And bone, there's a progressive loss of bone. And unfortunately for the ladies in the audience, once you hit menopause, you actually start pouring calcium out of your bones much faster. So to summarize that, you've got these two old structures. So the motor in both of these things has a lower RPM. The carburetor doesn't supply as much oxygen. The fuel lines don't provide as much fuel. The computer is slower and multitasks less well. The chassis is weaker, less flexible, and more brittle. And all of that is summarized in poorer performance for someone who is interested in competing as they get older. This guy, I tried to find pictures for you that were winter endurance sport things. And so that's why some of these look the way they do. This guy is quite unique. So he's an American speed skater, but at the age of 38, he accepted a challenge to lose weight. He was 275 pounds, and he started roller skating and gradually shifted to speed skating. And this is not a guy who was like a world-class skater in his youth and he just hung on. He wasn't at all. And he started, when he got really serious, he was training 3 hours a day, 6 days a week for 6 years. And at 53 years of age, he peaked in terms of his fastest times in his lifetime. And he actually finished second in the US 10K speed skating trials, the Olympic trials. So you don't see people very often who do that. It's usually the other way around, the great athlete who hangs on. Some of the psychosocial differences. I mean, this guy is out there, it's cold. He's looking up at the sky and thinking, I got a lot of things to do today besides this run, but I suppose it's supposed to be good for me, so I'm going to go do it. So he's probably got some family needs. He's got increasing professional responsibilities. We've just promoted in his business, so he's got more responsibilities. Got financial commitments. He's thinking of buying a cottage, so he's got that. And he's got social pressures. You know, my wife wants me to go out to this event, and I've got these other things that I'm doing. So all of those things are major distractions. They take away energy that these athletes have to train, and they really are, they do reduce motivation for people to train. So they do have different injury patterns, and there are, older athletes are subjected to 3 types of injuries. Old injuries coming back to haunt them, cumulative wear and tear, injuries from their current training. So, you all inherit those things. Younger athletes in general get injured doing stupid things. So they get more dislocations and fractures, etc. And older folks tend to get the itises. So they get arthritis, bursitis, fasciitis, etc., tendinosis, tendinitis. Older athletes will heal well. Now they heal, in my experience, just as well as anybody else, but usually slower. Other medications can complicate things if they've got comorbidities. You know, if you've got a knee that has a meniscus tear in it and it's also got arthritis, they don't heal, in my experience, as well as someone who's just got a pure meniscal injury. And then that connective tissue issue. So, you know, when you've got someone who dislocates their shoulder at the age of 12 playing hockey, they tend to be looser. And you got somebody who dislocates their shoulder at the age of 45, the issue tends to become stiffness because of this connective tissue issue. And you guys all may have different experiences, but I have never seen a frozen shoulder under the age of 40. So what are some concerns? Well, one of them for me is that not all joint pain is arthritis. And I get a lot of family doctors who refer patients into me with, you know, OA. And when you actually look at the patient, they don't have osteoarthritis at all. They have something else going on in their joint, particularly meniscal injuries. They deserve to be taken seriously because some of them have some serious goals. So this guy that you see pictured here, he actually set the world record for climbing Mount Everest at the age of 76. And some dude beat him and at the age of 80 took his record away by climbing Mount Everest. And at the age of 85, he attempted to get his record back and he died in that effort. But you can see, I mean, you think, geez, you know, you're 85 climbing Mount Everest, but some of these guys are very serious about these things. The bucket list issue. So I had a guy come in one day to the clinic and he wanted to climb to the base camp of Mount Everest. He was 67 years old. And I said, well, when do you want to do that? He said, in 6 weeks. And I need some help on terms of training. And I said, okay, well, what are you doing now? I walk 20 minutes a day. And where I live, you could fire a gun down the road where I live. It's so flat, it would never hit anything. So I said to this guy, well, good luck. I think you probably need to give yourself about 2 years to get ready. And he wasn't very happy with me. Instant results. So it took me 30 years to get out of shape, but I want to be in shape in the next 3 months. So even Superman would have trouble with that. There are increasing opportunities for aging athletes. There's masters competitions all over the place in track and field and in skiing and everything, I'm sure. And as you start to get rewards for this, performance enhancement is going to become an issue. It probably already is, where you're going to see people in this age group who are using anabolic steroids or growth hormone or whatever to try to actually win the gold medal at the Masters Games. And then there's the issue of the sins of the past coming back to haunt you. So this guy on the bike, you know, this is Rich when he was a little bit younger. And he just said, he wanted to be huge in his 20s and he wanted to be strong in his 30s. Now, as he's creeping into his 40s, he wants to stay healthy. And when he gets into his 50s, he's going to say, wouldn't it be cool if I didn't hurt today? Well, I'm in my 60s now, and I've noticed that it's payback time. So this, someday Rich is going to have this T-shirt with the Sons of Arthritis Motorcycle Club, and he's going to be in the ibuprofen chapter. So we'll see how that goes. So older athletes have to train a little bit differently, okay? It is the way it is. They need to start off slow and progress slowly, okay? You can't just go from zero to hero or Nintendo to commando in 10 weeks, okay? You gotta take your time. Warm up, you gotta do more of it. I've been training and racing for 52 years, and I actually need more than half an hour to warm up before I actually do something really intense. Although if you looked at me from the side, you wouldn't see anything really intense, but it's me pretending to be intense. You got to train consistently. Your cross training, that's essential. I now run, I now bike, I now swim, I now walk, I now race walk. You've got to vary up the load on your body. And strength training, you got to strengthen your core, got to spend more time on your upper body and your lower body because you're losing that muscle as you age. And they definitely need more time for recovery. Absolutely can't forget that. The big thing here is that aging bodies are less forgiving of training errors. So the other needs, reduce their high impact loads, less road work for runners, more elliptical, more pool, bike, etc. They even have zero gravity treadmills. Change the technique. So this guy you see, he's got a bad knee. He loves curling, and this is called stick curling or stirling. So he's using that stick to actually stay in the game. And I've had a couple of injuries where I've had to use, I'm a competitive curler and I've had to use that stick. And it's not the same, but it's still lots of fun. Keeps you in the game. Get them to lower the goals, make them a little bit more realistic. And as a last resort, maybe they have to change their sport because they just simply can't do it anymore. Above all, though, encourage them to keep moving, find something that they can do. So I love this picture because these two ladies seem to be having a hoot out there in the snow. They do have increased recovery needs, as we talked about. The older the athlete gets, the greater the amount of time that they need to recover from training and competition. And if you don't get adequate training, then training is just stress. It's not positive at all. And when you train older athletes with younger athletes, you've got to be very aware that the older athletes are going to have different rest needs than the younger competitors. So we're going to close with a couple of case studies here. So this guy says, my son has been diagnosed with diabetes and I want to do the Ottawa Ski Marathon in 2 months to raise funds for diabetes research. And this is what he looks like when he walks into your office. He even brought the Cheeto bowl with him. So he hasn't exercised in 20 years. He gets short of breath when he brushes his teeth too vigorously. He has high blood pressure, cholesterol, family history of heart disease, osteoarthritis. He hasn't started training yet. And what he really wants from you is to know which energy drink will help him achieve his goal. So this is a guy who is really a biological time bomb. And when he walks into your office, you need to actually manage his expectations and start him off a little bit more carefully to reduce his risk of injury, if you can do that. This second case, this guy, I have knee replacements and I want to know what I can do and what I should avoid. This guy is 73, I believe, or 71. He's been active his entire life. He stopped running years ago because it made his knees swell and have pain. He had both of his knees replaced 5 years ago, and he enjoys skiing, walking, cross-country skiing, and he has no pain doing these activities. So he's a highly motivated guy. My recommendation is encourage him to continue being active, try to minimize the amount of high impact that he does, such as running and jumping, and maybe get him to do a bit of swimming in the summertime just to offload those legs. In regard to that, with aging, there are concerns about activity and joint replacement. And so I've looked at this and I don't think this has changed. So there are 3 schools. The Knee Society discourages people from doing all of these things. So they say, don't do it if you've had a joint replacement. There are several studies done on high impact activities such as singles, tennis, etc. They showed no difference in failure of appliances. So they said there's no evidence to suggest that you can't do this stuff. And then FIMS had a position paper in 2008, that basically said pretty much do whatever you want. It's up to you. So I see people with this and I try to just to encourage them to minimize the amount of impact that they actually do, but to stay active for sure. So what are the take-home messages? Well, aging is highly individual and unavoidable. Most losses with aging are due to disuse and not aging itself. Some aging people are capable of incredible performances, as we showed you. aging competitors are structurally, physiologically, and psychosocially different. Aging athletes have different injury risk factors. Training needs of aging athletes are different from younger competitors. They deserve to be taken seriously. And I think that's very, very important. So I'll close with exercise is medicine, get moving and keep moving. And thank you very much for your time tonight.
Thank you, Darrell. Thank you so much. And I want to know how people got so many pictures of you exercising. It's simply incredible. And where were you at the Sons of Arthritis bike rally when I was there? So, so I have a couple of questions in the queue, and if you have questions, please please put them in the question and answer box, and I will work through a couple of them. This first question, Darrell, I think it's indirectly asking for personal experience and advice, but do you have any tips on helping aging athletes manage their expectations?
Yeah, so I think it helps if you have credibility with the person sitting in front of you. So if they know that you're an experienced aging athlete, that you have a bit of that. But I think the one thing that I try and do with them is develop a relationship with them. And then I try not to be brutal about it. I try to say, I'm not sure that this is a good idea for you. I don't think that you're putting your life at risk by doing it, but I'm not sure you're going to enjoy it if this is what you're trying to do. You maybe if you just slow down a little bit and you work towards that goal gradually, you may be able to get there, but I think you don't want to do this quickly. And if you can get them to slow down and try to move towards their goal, they will eventually come to realize on their own that I think the goal was unrealistic. If it's dangerous, I don't hesitate to tell them that I think this is very foolish and you're putting yourself at considerable risk. And my job is to tell you that. It may not happen, but my job is to tell you that.
Awesome. Question from Jean-Francois Germain. Should older athletes eat more proteins? I've seen recommendations from 0.9 grams per kilogram per day, all the way up to 2 grams per kilogram per day.
So I have a little bit of trouble with this because the body has a limited ability to actually make use of protein or incorporate protein, into you when you eat it. And for the average non-active person, my reading has suggested that about 0.8 grams a day will meet your protein needs. And if you have someone who is a very elite athlete, it's somewhere around 1.4 to 1.6 grams of protein a day. So if you try to jam more protein into you than your body will limit you taking in, your body's just going to produce fat and store it that way. So it doesn't work. If you're trying to load a little bit of extra protein, the only window that I know for doing that is immediately after exercise. Your body seems to be more receptive to loading protein, and it's about a 15 minutes to 2 hour opening, but it isn't huge. But if you're dealing with elite athletes who are willing to invest a long period of time, they may be able to put a little bit of extra protein on that way. Having said that, you do meet some older people who don't have very good diets. So suggesting to them to make sure that they're getting enough protein into their diet would be a very important thing.
Great. Kathy Campbell from Toronto says, thanks so much, Darrell. Great job. In regards to the joint replacements, don't you find that the older females need to be a little more careful related to bone density, or what are your thoughts? Cheers.
Hi, Kathy. Thanks. Good to hear from you. Yeah, I do think that is an issue because of osteopenia and osteoporosis, for sure. But I think that probably has to be highly individual. If you have somebody who has been very active their whole life and has built up a bank of bone that they can rely on, they can probably do very, very well. But if you meet somebody who is significantly fragile, yes, I think you do have to be very careful about that. But, you know, as I said, on a global perspective, not an individual perspective, I do think that it's not an absolute that you've had a hip replacement or a knee replacement, you are going to the boneyards and you're going to stay there. That's not true.
All right, so there's a note that was put in the chat by Keith Weber about your protein, and there's a good review on protein requirements over the age of 65, and he's included the link in there. Okay, so Valerie Hindle says, do you use the 10% rule or should it be 5%? And I'm guessing that she's talking to progression of exercise.
Yeah, great question. Thank you. So for those of you who may not be aware of this, until recently, it was considered best practices because we didn't have evidence to suggest how much you progress training. But we do know now from some studies that the coaches were actually correct, you know, in their practical learning from training people. So the general rule is no more than a 10% increase in training over a week. So if you're running 10 miles this week, next week, you should not be running 20 miles. And the following week, not 50 miles. It should be 10, 11, 12, 15 or 14, etc. In my own experience, it depends on the individual again, because some people really can't make that jump. It is 5, and some people it's even smaller. So I had a chance to work with Christine Gerard at the Olympics in 2012. In a 4-year period between Beijing and London, she increased her combined 2 lift weight by 3 kilograms to win the Olympic gold medal. You can imagine 3 kilograms increase in a period of 4 years, how tiny her progressions in training would have had to be. So it depends again on how high up and how close to the very razor edge you are of human performance. Your percentage of increase could be very, very, very tiny. But the 10% rule is not hard and fast. If you're going to err on the side of caution, use even less than that.
Okay, there's a question in the question box from Orlando Angulo, and it's about hormone replacement. And Orlando, if you look down in the question and answer, Alan Verneck, who is probably the leading authority with WADA, answered your question there. So just go down a little bit further in the question area. So I'm going to skip that one and go on to Peggy Hung, who asks, how do you advise a perimenopausal patient with insomnia what they should do with respect to recovery? For example, training program advises 1 day of rest per week, but they are always tired from the insomnia. Should they be doing more recovery days?
Yeah, so again, for me, this is easy if this person is doing this stuff for their health. So yes, there's no requirement for that person to say, I'm going to confine myself to actually training 6 days a week and it's an absolute, I only take 1 day off. There is no requirement for that. The second thing for that person that you could look at is how often are they training really hard? So let's pretend, because you'll see this. I mean, I see athletes who go out every day and they just beat themselves senseless, and they don't have recovery days. Their recovery day is that 1 day a week that they take off, and they never go hard, easy, hard, easy, hard, or hard, easy, easy. With world-class endurance athletes, they did a study and they asked them, what are their training schedules, et cetera. And they came up with another thing called the 80% rule. And what they found with world-class endurance athletes was that 80% of the time they trained relatively easily. Now, that is, you know, those guys, if I was to do their relatively easy day right now, it would kill me, but it's relatively easy for them. So only 20% of the time are they working hard. So make sure that that person isn't training too hard all the time. Get them to vary their workouts, you know, a hard day, an easy day, a hard day. And they may need to go hard day, or easy day, hard day, day off, easy day, hard day, day off, or some other variation like that. And if they're not comfortable with that, because some athletes aren't, the people that go, I'm not taking all that time off, then on their day that you're suggesting that they take off, just make it a really easy day. So let's pretend they're runners, and then this day, this active recovery day, get them to walk at a nice pace where they can still actually talk to somebody, so they get the sense that they're doing something. They're working on the health of their bones, but they're not overworking, and they are doing some recovery.
Awesome. Thank you, Darrell, for this amazing talk. There's a bunch of more questions that that Helen will send to you, and you can answer them, or you can go in during the next presentation to answer them yourself. You just have to type in the answers there. But if you do that, we will know that you're not paying attention to the talk that's about to happen.
I won't do that. I will pay attention to the talk.
Okay, so just give me 1 second, okay? We have a guest presenter coming up now, and so we're going to have an announcer introduce Dr. Trenholm. Dr. Trenholm's a sport and exercise medicine physician and a family physician in Huntsville. He's also co-owner of Reactivate Muskoka. He has particular interest in endurance sports, and he's chair of the Endurance Sports Medicine Special Interest Group for CHASM. He has a Master of Science in Biomechanics and has a keen eye for looking at the body as the sum of many moving parts. He specializes in gait and running analysis, concussion management, shoulder and lower extremity injuries. So give it up for Dr. Trenholm. All right. Hi, thanks for having me. Nice to see y'all. Okay, I just have to figure out one thing here. Get my presentation going.
The other guy was better looking.
Okay, well, I can do something about that. Okay, share screen, portion of the screen. And hopefully you guys can see my screen. Okay, can you guys see my screen?
Yes, I can.
All right, perfect. Okay, so we are going to talk about osteoarthritis in the active aging endurance athlete. I'll just increase the size of the screen a little bit here. There we go. And sorry. Okay, well, I'll just make it look like that then. Okay, so in full disclosure, I have no product endorsements. I have no pending research grants or projects, no financial affiliates, and no financial disclosures. Actually, I don't even get an allowance. So I'm just doing everything pro bono. So I'm trying to figure out how to change this so you can see. I don't know. I'm going to stop sharing. Sorry. And I'm going to come back and do this again because that's screwed up. Sorry. And there we go. That's better. Okay. So what are my objectives? It's my hope to be able to cover quite a bit of ground in 25 minutes. Our knowledge of how and why our population develops osteoarthritis is growing, but for some reason, the future trends are pointing in the direction of increased burden of disease on our population, as well as a reduced quality of life. In a global burden of disease study in 2000, osteoarthritis was the fourth leading cause of total years lost due to disease at the global level. And it's anticipated by 2040 that 25% of the adult population will have osteoarthritis, of which 50% will experience limitations directly attributable to osteoarthritis. Additionally, there's been a number of guidelines based on the available research, systematic reviews, meta-analyses that look at preventative strategies and management of osteoarthritis from a lifestyle, biomechanical, and systemic point of view. However, despite this, there's a real gross mismanagement of osteoarthritis for the vast majority of patients. In many ways, we're speaking about people, and even for ourselves who are endurance athletes, who are converted, who are active on a regular basis, who don't have the usual confounding variables that contribute to osteoarthropathy, like namely obesity. Historically, in broad strokes, like I said before, osteoarthritis has been grossly mismanaged despite the guidelines, and skipping over the conservative non-surgical management options, going straight to medications, and then while they await and palliate for an arthroplasty. It seems a little bit backwards. We're trying to improve the quality of people's life, full well knowing that we have to help palliate these symptoms while they wait for a surgery that may be months, years down the road. In endurance athletes, there's a few tweaks and adjustments rather than massive lifestyle overhauls that need to be done in order to keep them running, swimming, cycling, and enduring through sport. And I'll try to address some of those later on. One thing has to be kept in mind is that you can't change what they already have, but you can certainly change the rate at which their body progresses through the osteoarthropathy paradigm. So I ask one thing of us all. Currently, we're really good at identifying and diagnosing the resulting osteoarthritis due to years of cumulative dysfunctional mechanics and lifestyle issues that have led them to this point, and respond with treatment options for them. But what I ask is that you be an advocate for change. Talk to them and facilitate their management, make them part of your team, and don't just palliate them. I see it far too often with family physicians and primary care providers that the knee-jerk reaction is, rather than looking for the cause, they treat the symptom that they're having and really don't take the time to step back and look at things from a 30,000-foot view to be able to offer them the best possible care from a multidisciplinary approach in order to best improve their quality of life. So work with those around you and recognize and identify the precursors early, like the obvious obesity, smoking, sedentary behaviors, and engage with patients and colleagues to act for prevention and appropriate use of evidence-based treatments. And like I said, avoid the knee-jerk reaction to just dole out opiates and non-steroidal anti-inflammatories. I beg of you to avoid excessive imaging that does not change what you're going to recommend, or potentially even delay treatments and rehabilitative options that have an incredible impact with a little consistent and progressive effort. The only way that we can change the natural course of disease and alter the course of this looming epidemic is to improve the quality of life of aging, is to actually address the way people move and how they move, and the mechanical properties of their movements. So I know this is a busy slide, and I could spend the next hour talking about just this slide, but we know that exercise is good for patients. In national surveys in the US, 78% of primary care providers know that running at least does not lead to OA, and that's a huge shift from 20 years ago. They also know, it's also good to know, and I'll address this a little bit further in a future slide, is that what you see is not what you have. And only 30% of patients with radiographic osteoarthritis symptoms have changes. Why do we have, why are there changes that we see on x-rays? Well, it's because it's a long-term response to abnormal joint loading and compensation mechanisms at the structural musculoskeletal level. So, osteoarthritis is a form of an organ failure. If you think about it that way, it actually all falls into place. It results from excessive and poorly managed mechanical stresses applied to in the context of systemic susceptibility. One which carries a huge impact on a person's burden of health and is exponentially more common than conditions that we preach about, such as coronary artery disease, renal disease, diabetes, and has an absolute massive impact and trickle-down effect through their quality of life and the ability to manage other medical conditions. And you're going like, what organ is failing? Well, the organ that's failing is the synovial and musculoskeletal organ. Our body is asked to perform multi-joint movements that require strength, stability, neuromuscular coordination, and progressive failure and cumulative abnormal loading of these of our body to be able to manage any of these in the face of an underlying genetic or lifestyle susceptibility will result in osteoarthritis. So step back and look at the natural process of osteoarthritis. Abnormal and excessive loads causing the bone to respond by making itself more resilient to the forces by strengthening with subchondral sclerosis, osteophytic changes that increase the base of support at the joint level, joint space narrowing as the cartilage loses its elastic property and increases the joint surface area, like I said, with osteophytes. So getting old sucks, and only if you don't embrace it. So there's been a number of large-scale studies involving hundreds of thousands of people that have showed age-related improvements in performance and record setting. In fact, 75 to 79-year-old age group, good for you, Darrell, has seen the biggest gains in performance and power, and has seen the most world records being set. Now, that could be simply due to improvements in training and understanding physiology, but it also could be increased number of people who are engaging in the sport. And common things being common, well, they're usually common. So osteoarthritis is found in 13% of 55 to 65-year-olds and 17% of 65 to 74-year-olds, women more than men. And obviously, obesity, sedentary behavior, genetics, high bone density, and low vitamin D play a role. So this slide is going a little bit more into the imaging thing. And like I said before, imaging is grossly overused, over-relied upon, and you really have to think about, how is this going to change my management? The problem is patients are often looking for something to blame. Like they find that meniscal tear and like, oh yeah, that's what's doing it. Or, oh, that's where my joint is. Well, yeah, there's some element of that is true. But like I said before, only 30% of patients that have radiographic OA actually have symptoms. So there was a study that was done in 2003. They looked at 100 people and looked at both of their knees. And this one's really funny. One knee was symptomatic and the other knee was not. And they found that 57% of symptomatic knees had meniscal tears found on MRI. However, 67% of asymptomatic knees had meniscal tears in the asymptomatic side. It's just like even worse. They did find that radial, vertical, complex, or displaced meniscal tears and abnormality of the collateral ligaments, pericapsular soft tissue, and bone marrow are found almost exclusively on the symptomatic side. And these kinds of things appear to be a bit more clinically meaningful. So I'm going to go over looking at lower extremity mechanics. And these are a couple of things. And when we're looking at what we can change in our active population, looking at the biomechanical properties of what people are asking their body to do on a repetitive basis, whether it's swimming, whether it's biking, whether it's cycling, it's a repetitive activity that's happening over a period of time. Most of this stuff I'm actually going to be talking about running because running has a fabled increased rate of arthritis, which is what I've said earlier is not true. So if you think about this, running is not a series of sequential propulsive efforts. Running is a maintenance of forward momentum. Sorry, apparently Siri thinks I'm talking to it. And I've looked at hundreds of gait analyses. I've looked at elite runners, slow motion analysis. And one thing that I've noticed in analyzing the difference between recreational runners and elite level runners is that not only do the elite level runners, like Golden was talking about last week, land with their foot underneath their knee, but they literally hit the ground running. They're already starting the extensor moment at the hip when they make contact with the ground. So it's not a stop, move, kind of movement with running. It is a pushing the ground on. I'm just pushing my body forward a little bit further. So when we're running, we're like running on rickety stilts. We've got a vertical leg. We've got a large mass above that leg that is a center of gravity that's offset, that's causing a rotational moment at the hip and in the lower lumbar spine. And people are like, why am I having issues with my knees? Why do I have knee OA versus OA at the ankle or OA at the hip? It's quite actually easy to think about. So running is a close kinetic chain activity. The problem is you have a hinge joint that doesn't like rotational motion, doesn't tolerate it very well, that's stuck between two three-dimensional joint complexes at the hip and at the ankle joint. So your hips can tolerate the rotation, your ankle can tolerate the rotation to an extent, but then you've got this knee that's torqued in the middle. And when I'm talking to people who don't really understand the mechanics of it, I say, okay, go open up the door over there, and I want you to hang off the top of it. And when you're hanging off the top of it, I'm going to open and close it and open and close it. And what's going to happen? Well, you're going to pull the hinges out of the wall at the top, and you're going to compress the door at the bottom, and you're going to rub all the wood off. And that's exactly what's happening. You've got a joint that's under a large rotational load that is not designed to manage a rotational load. So three real simple things to look for when you're watching somebody walk or when you're watching somebody move. And the first part of your physical exam or your consultation is watching them walk in from the waiting room, seeing how they're moving, looking to see if their gait pattern is symmetric, looking to see if there's any shoulder drop, if there's any contralateral hip drop that might indicate lateral gluteal instability or weakness. Adduction moment. Are they trying to put their leg and their foot underneath their body more? So if this is your pelvis and your legs over here, are they trying to put it underneath here so that the base of support is directly underneath their center of gravity, which thereby reduces the actual work that the muscles in the pelvic complex need to actually do in order to propel themselves forward and maintain a natural posture. Another thing that Darrell alluded to, and Golden as well, is this dynamic internal rotation. So what's dynamic internal rotation? Well, when you are watching somebody walk or even run, you see that knee collapsing inwards. And that's a failure of the ability to control the velocity to which rotational movement is happening as you load that leg. We know that in people that do the therapy to control that rotational load, you don't necessarily have to get rid of that 100%. And this is something that I'll bring up again later, is when you're rehabilitating these people, it's not as much of the fact that they've got it or how much they've got it. There's a truth in the velocity to which that moment happens. So again, I use a lot of analogies in my practice, and I say it's almost like you're riding in your Camaro that has sport suspension, and you go over a bump, it can't absorb the shock because it just doesn't have the capacity to do. Or you go in your parents' Buick, and it's nice, cushy, you're floating on a cloud because it's able to dampen things, and the body can absorb that and manage that load with the improved shock absorbing potential of the periarticular muscles. I also encourage all of you to look a little bit deeper, and what appears to be the injury is not necessarily the cause. Dig deeper, look broader. I saw 3 patients in my sports clinic today that came with shoulder pain. All of them had subacromial impingement syndrome. And it's not because of a fact that the supraspinatus tendon is getting pinched, but it's a failure of infraspinatus and subscapularis to maintain an open subacromial space due to either their inactivity, their inability to respond appropriately when asked to work upon or call upon for an activity. And even broader than that, it's a failure of the inferior and medial stabilizing muscles around the scapula to maintain proper alignment of the scapula. And same thing happens at the hip. Yeah, I see a lot of people with Achilles tendinopathy with running. You get them on the treadmill, and you can literally see the extension moment with the thigh ending vertically, and the rest of the stance phase is the knee flexion and ankle plantar flexion with the main propulsive kick applied through the contraction of the calf and then the Achilles. So the Achilles gets overloaded because it's at the end of the chain. The body wants to move, 4 minutes or 5 minutes a kilometer, and come hell or high water, they're going to get there. And how's that going to happen? Well, in order to get that time, I need to push really hard with my calf. When in fact, the problem is higher up. The higher is you've got failure of your primary hip extensor, which is your gluteus maximus, and that has failed. And then it transfers the load onto the hamstrings, and that has not been able to keep up. So it has to get bolstered by the last remaining resort, which is the calf complex. So if you just fix the calf complex and you ignore the other things that are actually the causes of the issue, then you're not doing the patient any good. You're just solving what's down here and not what the main problem is. And I see that time and time again. Muscle groups also need to be addressed. The yin and the yang. Again, at the hip level, you've got people that come in with piriformis syndrome. Well, why do people have piriformis syndrome? Well, you've got 2 layers of muscles that are identically aligned. You've got the gluteus maximus, and then you have the deep gluteal system, of which you've got your piriformis, your gemelli, and you've got your quadratus femoris in there. And piriformis is perfectly aligned with the muscle fibers in the same direction as the gluteus maximus. And why do you get the sciatic symptoms? Well, you've got variations of how the sciatic nerve passes around the piriformis, but the piriformis is being over-relied upon and overused because the gluteus maximus is not doing the job. And so if the gluteus maximus is not doing the job, then the 4 smaller deep muscles say, well, this buddy up higher up than us isn't doing his job, so we got to pick up the slack. And so they pick up the slack, and the body can't tolerate it. You increase the load, you supersede the capacity of that muscle to manage that, and it fails and you get injured. So the treatment is, yes, doing some of the soft tissue work on the piriformis, but offloading those deep tissues back to the gluteus maximus, and then the piriformis and the deep gluteal system will settle down. Dysfunctional movement patterns, kind of going back additionally to the velocity discussion about internal rotation of the legs, planting your foot underneath you, or even crossing the midline underneath you, dropping your shoulder, finding out, and I'll talk about this again in a minute when I talk about gait analyses, looking for patterns of change on one side that might be affecting the other side, and things that are repetitive, things that come out in their with a bit of endurance. So when you get somebody on a treadmill, let them run for 5 minutes while you go do something else, so that they can start to show you actually what they can do when they're warmed up and maybe even a little bit fatigued. And look for the compensation biomechanisms. So when you've got somebody who's got IT band syndrome or piriformis syndrome, you end up seeing that leg dip underneath them because the muscular capacity of managing the body's center of gravity during the stance phase is not there. And so you put the foot underneath your center of gravity, so those muscles don't need to work as much. You see contralateral increased arm push when you've got somebody who doesn't have the contralateral hip or the gluteal strength. So they are engaging that deep oblique sling up higher so that it can generate more propulsive force all the way up your body to assist with that. So looking for those compensation biomechanisms and pointing them out to people. There's some great apps out there. I know Ryan went over a couple of them last week. I use Coach's Eye. It's pretty quick. You use it on the phone. You're able to do side-by-side analyses, which really, really help. So I'm going to head into some specific injuries, and the first one Darrell alluded to is the meniscus. So meniscus injuries and repair. So the meniscus acts as load sharers and shock absorbers in the knee, taking upwards of 70% of the load laterally and 50% of the load medially. And if you think about it, the tears are not the cause of the pain in osteoarthritis. They're poorly innervated, they're poorly blood supplies, and often the tears are the result of excessive and uncontrolled joint motion and velocities where the meniscus is acutely or repetitively loaded in an asymmetric pattern. So if you've got a abnormal joint where you've got tilting of the joint, you might have rotational and shear, you're compressing one side of the meniscus while applying a shearing and rotational force while you're distracting the other side. We know that it's a major predictor of future osteoarthropathy with a relative risk increase of 14.1 in patients with a previous meniscectomy. And studies have further backed this up to say 45 to 60% of patients or there's a 45 to 60% increase at 15 years follow-up with 50% of people symptomatic from having a meniscectomy. So when you're looking at that MRI report, if you get one, there are many different kinds of tears. And degenerative tears are something that are commonly seen. And they actually carry with it as an independent predictor a 7.0 relative risk increase for developing OA, versus a traumatic tear, which is 2.7. And why is that? Well, repetitive dysfunctional biomechanical loads that are done in an uncontrolled and repeated manner are going to lead to micro trauma over time and going to cause these degenerative tears to the meniscus. So yes, it's a relative risk increase of 7, but that's because it's an indicator of the perpetual ongoing biomechanical issues that the knee is exposing itself to. So at the end of the presentation, if you've had a patient that's had a meniscectomy or a meniscal partial resection, there is actually a table and a decision tool that you can use with your patients. You're going to get these presentations, and it's not a validated tool or anything like that, but it looks at the risk factors, and it's a good tool to help with discussions with your patients. Looking at this, this is a really good illustration that I used in a different presentation, and this is really the result of what a meniscectomy will do. The meniscus fills in the gaps between the tibial plateau and the femoral condyle surfaces so that you actually increase the surfaces over which the forces are distributed. You take that meniscus in, and it's like dancing on point. And you've got all of these forces, the same amount of forces that you were exposing over this large area to a really small surface area. And these things are like, little pillows underneath the sides of your joints. So they do avoid some excursion of the femoral condyle back and forth, where this has freedom to slip and slide all at once. So removal of the meniscus actually reduces the contact area by about 75% and increases peak contact pressures by, on average, 235%. So now on to ACL injuries and repair. So, ACL injuries and repair, about 77% of formerly young and active individuals who have sustained ACL injuries in the past actually end up with moderate to severe disabilities. The primary one is osteoarthritis. The relative risk at 12 years after an ACL rupture is 51% of women and 41% of men will have some sort of arthropathic change. It's got a preferential joint that it results in patellofemoral joint OA. And a lot of that's due to increased tone and tightness of the hamstrings, as well as post-surgical joint reduction. And the risk of OA in these patients is compounded with associated meniscal injury. Now, the good news is that numerous trials of neuromuscular conditions such as FIFA 11+ and soccer have demonstrated efficacy in reducing the risk of ACL injuries by as much as 60%. So you have to think, so why aren't we doing more to prevent ACL injuries in general? ACL injuries aren't just isolated to plant, pivot, and deceleration sports. They can happen, in a cyclist. They can happen in a runner, especially trail running or anything. Sudden change. They step off a curve by accident, or they're running around a dog that darts out at them. So it can happen. So really advocating for neuromuscular training for all. Core strengthening, balance training, plyometrics, lateral movements, rotational movements. All these things are important. So talking about running, is it really that bad? So studies, by and large, have been case control or prospective trials. There was a huge systematic review back in 2017 of 114,829 athletes looking at hip and knee OA in runners. And this kind of solidified everything for the myth of, do runners get OA? So in 13.3% of competitive runners, they had an incidence of running or of OA at some time in their life. And a competitive runner was noted at running more than 250 minutes a week, running more than 25 miles in a week, and or performing at a high competitive level. Whereas 3.5% of recreational runners actually had osteoarthritis at some point in their life. So it's actually protective, because look at 10.2% of non-running controls had OA. And so there's a sweet spot in recreational runners. And why is that? That is due to this low dose or recreational running effects. And there's this thing called a low cumulative load that means that the total amount of load accumulated over a period of time or distance is actually lower when compared to other activities that are static. And what's a static load? Well, static load is something where, like weightlifting, they're not moving, the load is going through their joints, they're trying to manage that load without doing small bursts of high intensity loading of the joint. So stride per stride, when you're landing on your leg, the peak forces are actually quite high, but the cumulative load over time compared to if somebody's doing weightlifting is quite a bit low. And you get in the more static the load, the lower the cartilage stiffness. And I'll show you a video after this slide. The loads deform the cartilage more, and more of the forces will actually transfer onto the underlying bone and impairs the anabolic biosynthesis in the cartilage. And this is why excessive body weight affects it as well. The cartilage can only take so much. Faster impacts like the running, I said, as higher peak forces per step will impart greater joint loads that are experienced across the whole articular surface, and the cartilage stiffness is higher. This is a video looking at a non-Newtonian liquid, and basically it's cornstarch and water. And so when they're running on this liquid, there's a matrix in the cornstarch that is retaining water. And if you load this non-Newtonian liquid quickly, it causes the water to get stuck in the matrix. I'll play that again for you because it's kind of cool. And it creates a stiff surface. So this is like if you're running. However, when you go onto the latter part where the guy falls down at the end, it's like a static load. He's sitting on this. So there's time for the water to displace out of the matrix. And when you have it going out of the matrix, it allows, oh, here he goes, the forces can go down deeper. Very cool. Non-Newtonian liquid. So here's a good graph summarizing all of this. So there is this beauty sweet spot down here in the recreational running, but there's a transition point where the repairability of cartilage and joints supersedes the ability to tolerate the loads that it's managing, and you get an increased injury risk as you go up with an increased running dose. So I use this chart not infrequently with runners when I'm explaining to them, why more is not more. So, do you need more convincing? Well, the cyclical loading results in responsive cartilage. The cartilage becomes conditioned to the stress that it is being asked to manage. This cyclical loading increases anabolic effects on cartilage. It makes the matrix more robust. Increased fluid goes into the cartilage matrix, which makes it thicker and more responsive to the forces it's trying to attenuate. Well, how do I know this? Well, cartilage tends to be thicker in load-bearing parts of the joint. And we've seen this in imaging studies with runners. We've seen conversely in patients that have been immobilized either temporarily or permanently, and they've demonstrated that there's reduced cartilage volume based on indices of cartilage quality and robustness on MRI. And acutely, when compared to walking and stair climbing, running causes reductions in cartilage water content and cartilage realignment in compartmental cartilage, primarily of patellofemoral and the medial compartments. However, 1 hour post-run, these parameters actually increase back to and even supersede the baseline levels. So there's a study that compared young versus old after 2.5 hours running. The differences were only ever seen in the superficial layers of cartilage in response to exercise. So runners over time have more resilient cartilage. So prevention is the best management. And, the first thing I'll talk about is, I'm not going to go into much more deeper because Golden talked about it a lot, is this postural control. So run tall, run proud. And when you do that, your body will align, your pelvis will remain in a neutral position, and using that cue will really, really help. Rotational control and rotational stability, like I was talking about when you single leg plant and you're trying to control the dynamic internal rotation, and biomechanical studies have supported that have shown that athletes that have a greater resilience to rotational control at the lumbar, hip, foot, and ankle joints have lower injury rates. So, I will take a few minutes to explain the purpose of an exercise prescription to patients and the role of the rehabilitation specialists, such as the athletic therapists, the physiotherapists, chiropractors, massagers, that I'll be working with. The exercises don't have to be complicated or numerous. Exercises have to be done with purpose to create neuromuscular patterns. They have to be progressive to cause adaptive change. And they have to be done in a controlled way to teach concentric and eccentric muscle groups to work together to control the excessive joint motions and joint velocities. Additionally, they have to be done consistently to be able to change the capacity for tissues to be able to withstand loads. Strength and conditioning is often seen in done in a single plane: squat, deadlift, even lateral lunges or walking lunges. And one simple tip to take away to add in this rotational instability would be to strap an exercise band or TheraBand around your knee that's trying to pull it rotationally on either an external rotation moment or an internal rotation moment while you're performing that squat. And that is going to teach your body to control that rotational moment through a range of motion in the frontal plane that you're trying to run. The same thing you can do if you're exercising laterally. If you're doing lateral step-outs, have something that's pulling you forward or pulling you backward that you're trying to stabilize. And you can do the same things without a resistance to that extent by doing some of the exercises on a non-stable surface. So as an athlete, you need to be able to steer your parts in control to the degree and the velocity to which the joints perform their linear translational movements. I didn't spend a lot of time talking about drugs. Drugs are okay. And I'm assuming that many of you are already familiar with pharmacologic management of osteoarthritis. But it must be noted that these medications don't necessarily change or alter the course of the disease progression on their own. However, they do allow for pain control, which would facilitate an individual to engage in strength and conditioning exercises or even gait retraining or technique retraining, such that they lower the rate of progression of osteoarthritis. Things like structural supports, mainly like offloader bracing or kinesiotaping can even help. Those kinds of things can help somebody do the exercises so that they don't need them anymore. Your body is a machine. Treat it like one. Mindful running. When I teach people, the first thing I do when I get somebody on the treadmill is I don't look at them. I close my eyes and I actually listen to them run. I want them to pay attention to what their body's doing, just like I do. So I listen to, like you do, listen to the hum of a car motor or listen to the clank of an exhaust pipe as it's dragging on the ground. I listen to the rhythmicity and the volume differences as each leg goes through the stance phase. So I encourage people to do the same. Listen to their body as they're running. Make sure that it's rhythmic, that the volume of footfall is the same on one side to the other. Feel the upper body tension, and a practical takeaway for people, like everybody says, oh, let your shoulders drop. Simple trick is actually taking your fingers and pinching them like this. You pinch your fingers when you run. You can do it even right now. You'll feel your shoulders drop as soon as you pinch your fingers. Some people I tell, grab a stress ball and run with the stress ball in each hand and don't squeeze them. And that drops the tension in the upper extremities. Feel the elbows as they come close to their side, like Golden was talking about. They shouldn't get in front of the midline of the thorax. And feel what's happening with the feet. Feel where the forces are hitting the feet. Are you more on the lateral because your foot's swinging underneath you? Those kinds of things are super important. Your body's a machine. Treat it like one. You're going to, if you had a Camaro, which you should treat your body like, you take it to a body shop, you get it detailed, you get it buffed, you get it waxed. You'd also get things attended to. If you heard your car making a funny noise, you take it to the shop. So the same thing, you got to do this with your body. Get massages to keep the muscles pliable, reduce the compressive joint forces that are caused by the muscles that are at increased tone going across the joint surfaces. Chiropractic therapy, acupuncture, and just like you would do for a bike fit on a fairly regular basis, go get a gait analysis. Like it makes so much sense because your body is the machine. So I've got this in here. This is a quick and dirty assessment. What I'll try to do is I'll try to record a video so that Helen can send it out. And this is my high yield lower extremity assessment that's both dynamic and static, that looks at things in a three-dimensional plane that you can do in your office. And Helen's given me the 5-minute warning, so I got to get off of here to give Brittany some time. There's a couple of other slides at the end of this presentation that will come out, and they're more reference slides for your intervention and your education. But I'm going to stop there, answer some questions that you may have, and hopefully you guys found this useful and practical. So thank you for taking the time to listen to me. Yes, only one question. Yes. So Roger asked me, osteoarthritis can be degenerative, but also can be post-traumatic. Yeah, I agree. It can be post-traumatic, but really what is the post-traumatic change? So the post-traumatic change causes alterations in mechanical alignment. It changes neuromuscular contraction properties and patterns. it can change, if there's any ligamentous or structural integrity and injuries. It's going to alter the ability to withstand the excessive and uncontrolled joint forces. So yes. Why does pinching your fingers cause your shoulders to relax? I don't know. Ryan Grant told me this when I attended a conference of him, and I started running like this. And whether it is you're pinching your fingers and it causes some neurologic reflex, or I can't explain it. It just works. So give it a try, Megan, next time you're out for a run. It's weird, but it works. So do hyaluronic acid injections slow OA of the knee? And to any of the questions that I've already answered, and I'm leaving your questions up here. If I didn't answer it properly, or if you got a follow-up question to what I said, please put it in there and I'll look at it again. So do HA injections slow osteoarthritis of the knee? Well, technically they can, and it really depends on when you apply that treatment. The treatment will, if applied early, will improve the ability of cartilage to produce the synovial fluid to improve function and the slippery environment inside the knee. So if you think about what's the role of viscosupplementation, it goes into the knee and it acts to wake up active chondrocytes. In early arthritis and moderate osteoarthritis, you have cartilage cells, the chondrocytes, that are stunned. Basically, they don't know what's being thrown at them. They've got all these forces that they're trying to deal with, and they're stunned. The visco goes in there, wakes up the chondrocytes. They make more slippery fluid, makes the joint, better function, almost like adding, some A535 or not A535, some WD-40 to a squeaky wheel or a squeaky joint. You're going to end up having to replace that joint at some point if you don't take care of it and don't keep it lubricated. But it improves the lubrication. So can it alter the course? I don't think that, well, not to my knowledge, there's been longitudinal studies that looked at how they've altered the course of the OA progression. But it makes sense that it would. But I give you the caveat of doing that as an early adjunctive therapy in combination with the exercise therapies to control the poor biomechanical control. Okay, so at high running volume, you mentioned you lose the protective effect of running. Is there a cutoff volume that defines high versus low running volume? And that's from a couple of people there. So the studies that have been done have largely been looking at the recreational runner being at less than 250 minutes of running in a week, running less than 25 miles in a week. Some studies look at the competitive runner that has the increased risk of OA. They've said anybody who's competed at the elite level, the national level, went to a major games, those are the people that they've defined as having increased risk. It's a fairly loose definition. So like Tracy is saying here, you've got some slower runners like 7 or 8 minutes per kilometer. So would I think the time or mileage for these athletes in terms of volume? Yeah, I would probably look at more at the volume, the distance that they're covering. And I'm sorry, I don't have a clear answer because there's not hasn't been well-designed studies that have people saying, well, I'm going to run, you run 30 minutes and you run 35 minutes and you run 40 minutes. So there aren't studies out there that are like that. So anyways, yeah, there's lots of there's lots of stuff that can be discussed about this. Yeah, like I love biomechanics. I love the biomechanics of running. And if any of you guys have any questions, please reach out to me. It's rich@reactivate.muskoka.com. That's my email address. or reach me through Helen or on any of our social media pages. I'd be happy to help anybody out. So thanks. And I'm going to go on to Brittany. You ready, Brittany? Right, you got it.
I'm ready.
Stuff there. All right, let me go into, you don't get the fancy hat unless you want the fancy hat.
Can you throw it over here?
We'll see, where is it? Okay. So Brittany Vandyken is a registered physiotherapist and co-owner of PhysioWorks, Muskoka, and Reframe Rehab. She graduated with Honors Bachelor of Science degree from Brock University in 2014 while playing as an academic All-Canadian on Brock's varsity basketball team. Following this, she obtained her Master's of Science in Physiotherapy from McMaster University in 2017. She's received additional postgraduate training in soft tissue release, pelvic floor rehabilitation, breast health, and oncology rehabilitation. Brittany has a passion for clinical research on lumbopelvic pain and pelvic floor dysfunction, recently publishing several research papers on these topics in the Journal of Musculoskeletal Science and Practice, Brazilian Journal of Physical Therapy, and Physical Therapy. So thank you so much, Brittany, for taking the time to be a part of this lecture series, and take it away.
Thank you, Rich, for the introduction. It's a pleasure to be here tonight. Always tough to be the last to present. Two awesome and informative presentations. So thanks, Darrell and Rich, for those. I'm going to go ahead and share my screen. Okay. Okay, can everyone see that? Beautiful. Okay. So tonight I'm going to be talking about what I like to call the forgotten muscle group in athletes, or pelvic floor considerations in the endurance athlete. Disclosure, I'm not receiving any fees or any funding. Like Rich said, I do have 2 for-profit clinical entities, which I will not be referring to in any way during this presentation. So our learning goals for this presentation include to discuss the prevalence of pelvic floor dysfunction in endurance athletes, understand that pelvic floor dysfunction can include hypotonicity and hypertonicity of the musculature, and that Kegels alone are often not adequate, and identify the basic skills and questions required for addressing pelvic floor dysfunction in the medical office and when to refer on to pelvic floor physiotherapy. Quick anatomy review. So this is our pelvic floor, collectively called the levator ani, and extends from the pubic symphysis at the front to the coccyx at the back, in between our 2 ischial tuberosities. In the rehab world, we think of it as having an anterior triangle, which contains the vaginal opening and the urethral opening, and a posterior triangle, which contains our rectal opening, with each triangle playing equal importance. The pelvic floor has 5 functions. And interestingly, the pelvic floor is the only musculoskeletal muscle in our body that does 5 different things. And it's often one of the muscle groups that we forget the most about in our athletes. So the first function is stability, providing structural and stabilizing support to the lumbar spine, the hips, and the pelvis. The second function is sphincteric support, or preventing bowel and bladder incontinence. The third is support of our internal organs, including our bladder, our uterus, and our rectum. Fourth is a sexual function, so it plays a role in both dyspareunia and anorgasmia, as well as ED and sexual function in men. And the fifth is a sump pump function, so helping with venous return back up to the heart. So very busy set of muscles. In a recent clinical review in 2019 on pelvic floor dysfunction in female athletes, pelvic floor dysfunction is collectively termed as issues within the pelvic floor muscles. And there are 2 main types: relaxing or weak hypotonic pelvic floor dysfunction, which is the most common and the most commonly researched, and non-relaxing or tight or hypertonic pelvic floor dysfunction, which is less common and less researched, although the evidence behind hypertonic pelvic floor dysfunction is certainly increasing. In terms of signs or symptoms of a relaxing or weak pelvic floor, the most common and most researched, especially in the athletic population, as you'll see shortly, is stress incontinence. You also can see urge incontinence with a weak pelvic floor, mixed incontinence, prolapse, cystocele, rectocele, or uterocele, as well as anal incontinence. In the non-relaxing or hypertonic pelvic floor category, we often see signs or symptoms including constipation, inability to evacuate urine effectively or fully, lumbopelvic, pelvic girdle, or pelvic pain, and dyspareunia. There is actually an athletic disadvantage for your pelvic floor, which can be shocking and surprising to many people. So in a recent meta-analysis in 2020, they found that pelvic floor dysfunction in high-performance athletes is associated with their athletic activity, and that urinary incontinence is actually greater in athletic women versus non-athletic women. Other contributors to urinary incontinence that they found in athletic women include eating disorders, constipation, a family history of urinary incontinence, history of UTIs, and decreased flexibility of the plantar arch, some of that biomechanics Rich was talking about a few minutes ago. So these are all associated with an increased risk of incontinence in our female athletes. In this meta-analysis, when they looked at pelvic floor muscle training for urinary incontinence in elite female athletes, former elite female athletes, as well as pregnant athletes who were regularly engaging in aerobic physical activity, pelvic floor training actually improved incontinence gain greater than those by non-athletic women. So we know that pelvic floor dysfunction is actually greater in our athletes, but we also know, according to this meta-analysis, that the outcomes are better with pelvic floor training than in non-athletes. So let's talk a little bit more specifically. In this cross-sectional study, they looked at 372 elite athletes with equal age-matched controls. And this looked just at urinary incontinence. And overall, the prevalence of urinary incontinence was 29.6 in athletes versus 13.4% in non-athletes. So when they did the statistical analysis and the adjustments, the odds ratio for developing urinary incontinence in athletes was 3.31 compared to those non-athletes. So it was a significant finding. If we break this further into some of the different endurance sports that we all see clinically, in an online survey for over 300 triathletes, 37.4% of them reported stress urinary incontinence, 28% anal incontinence, 16% urge urinary incontinence, 5% prolapse, and 18% pelvic girdle pain. Looking at other studies in endurance sport, Prosoita found that 45.5% of endurance athletes, which included in their study both cross-country skiers, so our winter sport, as well as our runners, reported urinary incontinence. And 62.2% of long-distance runners also reported urinary incontinence. So quite common in our endurance sport populations. In the rehab world, we often have the debate of what causes more pelvic floor dysfunction, endurance sport versus CrossFit. So they just recently in 2020 looked at an online survey of over 1,300 women, over 500 runners, over 800 CrossFitters. What they found was that in general, running seems to have a greater impact for pelvic floor dysfunction. So runners had higher pelvic organ prolapse and higher anal incontinence compared to CrossFitters, and this was statistically significant. There seemed to be no difference in stress urinary incontinence between CrossFitters and runners, although if you look at the percentages, 37% in runners, 41% in CrossFitters, that's still quite high. So many of our athletes are struggling with this. They then looked at parity. And again, when we're looking at the aging endurance athlete, parity often comes into play and is something that needs to be considered. So vaginally porous runners reported significantly more symptoms of pelvic organ prolapse, anal incontinence, and urge urinary incontinence than CrossFit Paris athletes. So overall, running seems to have a greater impact on pelvic organ prolapse and anal incontinence rather than CrossFitting. However, both have high prevalences in these athletic populations. So we've talked about what the pelvic floor is, what is pelvic floor dysfunction, and the higher incidence in our athletes, particularly endurance athletes, even greater than strength athletes. Does it actually affect our athletic performance? And the research says it does. So based on several papers and reviews, we can see that, and again, stress urinary incontinence is the most common and the most heavily researched in the literature, but stress urinary incontinence is a barrier to women's participation in sport and fitness activities. It impacts women's quality of life, their health, their self-esteem, and their well-being. And it's actually been shown to be linked to a decrease in our athletic performance. It can do this because of a change in sport or in training volumes. So women might withdraw from a sport. They might change how much they train or how they choose to train because of their incontinence or pelvic floor dysfunction. And ultimately, it does result for some women in avoidance of physical activity altogether. So this plays an important role when we are looking at our athletes, particularly our ones that want to be competitive, but I will argue any athlete because it has a significant impact on our quality of life. Like I mentioned at the beginning, it can seem strange or odd that our pelvic floor dysfunction might be higher in the athletic population. So a great review came out just a year ago in 2019, and she summarized the evidence for pelvic floor dysfunctions in the female athlete. And what she talks about is when we have increased amounts of intra-abdominal pressure in exercise, over time, that sustained load seems to be correlated with a decreased strength of our pelvic floor muscle contraction. On dynamic imaging studies, we also see that in athletes, we have hypertrophy of the pelvic floor muscles, yet with this larger increase in mass, there's increased bladder descent on this imaging, and we see that mass does not equal function for our pelvic floor muscles. When they're looking at endurance exercisers in particular, endurance exercisers show a decreased max voluntary contraction of their pelvic floor muscles. And when you compare your endurance athletes to your walker athletes, there tends to be more vaginal descent in our endurance athletes and decreased pelvic floor muscle resting pressure. And this appears to be dose dependent. So the more activity someone does in their training regime, the more dysfunction we tend to see in the pelvic floor. So we've talked about the mechanisms, we've talked about what pelvic floor dysfunction is, but is there evidence-based help for our athletes, or are we wasting our time? So there have been several Cochrane collaboration reviews and analyses on pelvic floor muscle training for urinary incontinence, as well as all types of incontinence, 2010, 2014, 2018. And these reviews show level 1, grade A evidence for retraining pelvic floor function based on internal palpation of the pelvic floor muscles for urinary incontinence, which includes stress incontinence most commonly, as well as other types of incontinence, such as urge urinary incontinence and mixed urinary incontinence. In 2008, the Canadian Physiotherapy Association, in a joint position statement with the Society of Obstetricians and Gynecologists in Canada, stated that assessment for pelvic floor muscle training needs to include a digital, vaginal, and/or rectal examination of the pelvic floor muscles. It is no longer best practice, according to the CPA and the SOGC, to hand a woman a sheet of Kegels and hope that they're done correctly. It must be done with an internal examination. Carrie Bowe, who is a prolific pelvic floor researcher, has studied the rate of urinary incontinence, pelvic floor dysfunction in exercise and sport, and published several reviews and analyses on this. In her review, she looked at all the randomized controlled trials on female athletes for pelvic floor muscle training. They defined a cure rate as less than 2 grams of leakage on pad tests, and in the review stated that between 44 and 69% of pelvic floor muscle training in athletes results in a complete cure rate. She concluded that pelvic floor muscle training has no serious adverse effects and has been recommended as first-line treatment in this population. So there's high evidence for training the pelvic floor to help with stress urinary incontinence, but what about pelvic organ prolapse, another common disorder we see in the athletic population? I would say that the POPPY study, which came out in 2014, really kicked off high quality research, which we've seen evolve in the last 8 to 10 years. The POPPY study was a parallel group, multi-center, randomized, and actually multi-country controlled trial at 23 centers with over 400 participants. They either had one-on-one physiotherapy for pelvic organ prolapse or education and lifestyle advice for prolapse management, and included stage 1 to stage 3 prolapses. What they concluded was that one-to-one pelvic floor muscle training for prolapse is effective for improvement of their prolapse symptoms. Since 2014, the robustness of this evidence has continued to increase, and we now know that there is strong evidence to conclude that training for your pelvic floor is effective, cost-effective, and safe in reducing prolapse symptoms. And we now think this should be considered and recommended as first-line management for prolapse, often before surgery. I just really want to quickly go back to what we talked about in the beginning, where we said there was, again, weak hypotonic pelvic floor, and then hypertonic or tight pelvic floor. I'm just going to highlight one really quick study on the hypertonic pelvic floor that just came out that I thought was fascinating in athletes, particularly. The evidence for hypertonic pelvic floor often looks at the general population and isn't specific to athletes itself. So the study had 40 nulliparous continent and incontinent professional female athletes. So low study numbers, so definitely some weaknesses there. It was a cross-sectional study. And what they found was that in incontinent athletes actually had greater pelvic floor muscle strength than the continent athletes. What this suggests is that in some athletes, urinary incontinence is not always due to pelvic floor muscle weakness. There was a positive association between abdominal and pelvic floor muscle strengths in the incontinent athletes, which might be due to the frequent co-contraction between those muscle groups. So what we think is that in athletes with increased intra-abdominal pressure and the loads of sport, just like we can get overuse injuries in other parts of our body, we can get overuse in our pelvic floor, and we can create tension in the pelvic floor muscles, which can also contribute to stress urinary incontinence and other types of pelvic floor dysfunction, particularly the non-relaxing or hypertonic kind. Like the SOGC and CPA have published, we cannot truly know what is causing pelvic floor muscle dysfunction without an internal exam of these muscles. So it may not be all about Kegels, and it's important to consider the option that we might need to restore proper mechanics and proper length tension relationship in the pelvic floor. And the pelvic floor needs to coordinate with other lumbopelvic musculature. So Rich was talking about in his talk about the layers of the glute and then our rotators piriformis, and the pelvic floor has a function in lumbopelvic stability as well and needs to be considered when we're talking about biomechanics, gait analysis, and load transfer. So if we know that there are highly effective strategies, who are the professionals that can start to look at this? One professional, and the most common professional in the literature, are pelvic floor physiotherapists, although I know some fabulous physicians, naturopathic doctors who are also working in this area. Pelvic floor physiotherapy is the assessment and treatment of pelvic floor dysfunction, and it's done by a rostered physiotherapist. Now, I'm in Ontario right now. In Ontario, and I'm pretty sure in all the Canadian provinces, you must be rostered with a physiotherapy college, which means we need additional training. And to prove we've done that additional training, because it involves internal assessment and exams, we might look at conditions including incontinence, pelvic pain, including sexual pain, low back pain, pelvic girdle pain, and hip pain, pelvic organ prolapse, bowel and bladder pain, and elimination dysfunction. Pelvic floor physiotherapy involves many different aspects, including an internal, vaginal, and rectal examination of the pelvic floor muscles, assessment of external musculoskeletal lumbopelvic contributors, pelvic floor muscle lengthening and stretching exercises, again, looking at that hypertonic aspect of the pelvic floor, manual therapy of the muscles, pelvic floor muscle strength training, addressing the hypotonic aspect of the pelvic floor, bowel and bladder training, and sport-specific training. In Ontario, all pelvic floor physiotherapists have to be rostered with their college. So if you're looking for one in your area, you can go to collegept.org to look that up. If you are not in Ontario, if you Google search the College of Physiotherapists for your province, again, they will have a rostered list as well. So what are the barriers for physicians or primary care providers in looking at the pelvic floor and addressing pelvic floor dysfunction with our athletes? The first is difficulty discussing pelvic floor health. There is often a level of patient embarrassment, or many women don't know that there is evidence-based help for their issues, or many female athletes feel ashamed because they think that as athletes, this should not be happening to them because they're strong. The second barrier is assessing pelvic floor function in the office. Often, many providers are not trained to look at the muscles in particular and assess tone and strength and coordination with the other lumbopelvic musculature. And there are quite obvious time constraints within your practices as well. The third barrier is access to physiotherapy care. Not all regions have physiotherapists that are providing internal muscular assessment, although this number is growing and most regions have at least one. And one of the biggest barriers is cost of physiotherapy. So as most of you know, physiotherapy is not covered under OHIP and is covered out of pocket for individuals or with private insurance plans. when we look at incontinence and cost, I always like to bring the 2014 Canadian Continence Society Commission report that came out. So the Canadian Continence Foundation estimated that in 2014, which is quite a long time ago, so we estimate that this has increased, that incontinence, the direct and indirect costs $5.13 billion a year in total in Canada, which works out to just over $6,000 per individual per annum who is incontinent. Now, again, take with a grain of salt that that includes institutionalized and community dwelling. When the Canadian Continence Foundation broke this down further, community dwelling adults, which is our athletes that we are seeing in the clinical setting, that they spend $1,000 per year in some form of incontinence supplies or products. So if we look at the evidence behind pelvic floor muscle training, on average, it takes anywhere between 3 to 7 sessions over a period of 2 to 4 months to become significantly or completely continent again. And that on average works out to be about $500 to $700 per person. The longevity of pelvic floor muscle training is very high. So it works out to be significant cost savings for the individual. So I always bring that up with women when we're trying to discuss finances and the risk benefit analysis of that. So how can we start having this conversation better in our primary care practices and in our practices with the athletes? So I had the pleasure of publishing 3 studies with a research group out of McMaster University led by Dr. Sinead Dufour. And so we created what's called the Primary Care Pelvic Health Screen. It's a 9-question questionnaire based on the evidence supporting signs and symptoms of pelvic floor dysfunction, as well as expert opinion. And we've been able to test this questionnaire in research. It is quick and easy to fill out. The benefits of this is it helps to remove patient and physician embarrassment or barrier to having this discussion. It can be used standardly with all your patients or athletes coming into the clinic, and it opens up the conversation of pelvic floor health. Our research has showed that if someone checks off at least one box, then when we did a blinded physical exam of their pelvic floor, it was 100% predictive of them having some kind of pelvic floor dysfunction. What we cannot say from certainty in our research is that certain signs and symptoms of pelvic floor dysfunction predict whether they're hypotonic or hypertonic. All we know is a yes, no. Yes, if they check off something, they have some form of pelvic floor dysfunction. No, they don't check off anything. We can be reasonably sure that they don't have pelvic floor dysfunction, but we can't tell what kind from this questionnaire, at least not yet, although there is some further research being done. The reference for that is at the bottom. So in summary, what can you do in the clinic? What can you start in your practices tomorrow to start to address the missing muscle group in our athletes? First, ask the question to our athletes. Use the screening questionnaire if you don't want to ask those questions, or if you want to use that as a launching point. You can learn how to assess the pelvic floor in the clinic, looking for hypertonicity, hypotonicity, coordination, and strength. Again, it's not all about weakness and Kegels, and it is considered best evidence and best practice to do an internal exam to assess our pelvic floor muscles. It is no longer considered best practice to hand a woman a sheet describing how to do their Kegels for them. So that's actually outdated evidence at this stage. You can refer to a physiotherapist in your area if your client is interested. Again, look at your governing body's website there. And don't forget about young and nulliparous women athletes. There is a really large body of evidence looking at pelvic floor dysfunction in young and nulliparous women. So this is not just for the aging athlete, although they're certainly at a greater risk, often due to parity. And then as well, menopausal changes can have a huge shift on that. And pelvic floor dysfunction, leakage, incontinence, and pain can also occur in men. Thank you for listening today. I hope that you were able to learn something new about addressing pelvic floor dysfunction in your female athletes. Our athletes are highly impacted by this. It is very prevalent in this population. They deserve to know that there is help, and it's important that we can begin this conversation with our athletes. Thank you. Here's my email at the bottom if anyone wants a copy of resources or that screening questionnaire.
Awesome. Thanks, Brittany.
Thank you.
That was great. We do have a couple of questions for you. Roger Hobden has a couple. The first one is, do male athletes have pelvic floor dysfunction, trigger points, etc.?
Absolutely. Really great question. So there's I often talk about in research that there is a disparity for women, that women are often less researched. I would say pelvic floor research is one of the only areas in health where men are actually heavily disadvantaged. There is very little male research out there. Now there is that research, is just less prominent. The stats will say that 1 in 3 women suffer from pelvic floor dysfunction. Now this is globally, not athletics. 1 in 9 men, so it's about 3 times less common. But yes, men will get trigger points, myofascial pain in their pelvic floor. It will result in urinary incontinence as well, to a lesser degree. Male athletes tend to have more urinary hesitation, voiding problems, what they perceive as chronic prostatitis or pain in the penile area, and erectile dysfunction. Men actually tend to have more hypertonic disorders rather than hypotonic compared to women.
Do you find, just my own personal question on top of this, so do you find that there's a relation, because I talked about in my talk about opposing muscle groups. So if you've got somebody who's got gluteal dysfunction or deep gluteal system, and you've got, iliopsoas or iliacus tendinopathy, is there a role for a pelvic floor physiotherapist in helping manage those, not like right at the triangles, but close to the triangles? Is there a role for you guys for that kind of thing?
Yes, absolutely. We do see again that they share many common areas, and we start to see cross muscular sensitization with that. So I do treat many people with some of tendinopathies, impingements, and we see quite a lot of hypertonic. So again, those would be people that don't need Kegels, don't need strengthening. They actually need lengthening, and we see a lot of hypertonicity within their pelvic floor muscles, especially around those general insertions. The other thing that we see quite interestingly is that piriformis and obturator internus, so our rotators in that area, the bulk of that muscle belly lies within the vaginal wall. So though it's not part of the true levator ani, the piriformis and the obturator internus suspend off the lateral wall, and we can access that quite nicely vaginally and actually beautifully rectally. So I see a lot of people with chronic piriformis syndrome or sort of chronic ischial tuberosity pain or GT tuberosity pain, where it's actually the muscle belly, and we can get at it quite nicely from the pelvic floor from a myofascial perspective.
Awesome. Alana Tope, hopefully I'm saying your name correctly, had a question. Can you have a mixed hypotonic and hypertonic picture with symptoms that overlap?
Absolutely. And I would say clinically, that is what I see most commonly. About 8 times out of 10, I'm seeing a mixed picture where someone has hypertonicity and then hypotonicity as well. And as rehab professionals and sports med physicians, we always get to resolving that tension before strengthening. So that individual would start with stretching, manual therapy, down training of their pelvic floor, iliopsoas, glute med, all of that good stuff, and then finish off with Kegel training or strengthening. But then it makes sense. When those muscles are weak, they're going to be overworking. We're not giving them the rest, and then they start to get into a hypertonic state.
Okay, Tracy Teasdale has a question. If a clinician is interested in learning more, where would you send them?
Awesome. So I will declare my conflict of interest here. So I co-own Reframe Rehab, which is a continuing education company that teaches rehab professionals and medical professionals how to have an external perspective on the pelvic floor. That's one option. The other really great option is Pelvic Health Solutions, which I have no financial interest in, and they will do all your internal training courses as well as an external course. So I would look at Pelvic Health Solutions particularly, and they're a Toronto-based company, particularly if you're wanting to learn the internal assessment, diagnosis, and treatment. And then I'm happy if you email me directly some really fabulous websites and recordings on putting that into a very athletic and sport-minded manner.
Okay. I'm going to do 2 more questions here. And Jane has a question. Says, thanks for your presentation, Brittany. I can see an athlete filling out that questionnaire with all no's, but still having feelings of prolapse, incontinence, etc. during exercise, jumping, squats, that kind of stuff. How do you frame those questions? And is there a separate validated questionnaire?
Yes. So if we go back 1 second, give me 1 second. So if we look at, the second last question is, do you experience pelvic pain or pelvic pressure, vaginal, rectal, penile, testicular, bladder, tailbone, or pelvic girdle pain? For the most part, we will often see that women will check yes to that with pelvic organ prolapse, because the most common symptom is that pressure, that heaviness, that tampon falling out of the vagina feeling. However, there is a couple other great validated questionnaires, the POPQ, and I'd be happy to send those out as well to look at that.
Okay.
None of them specific in the athletic population, but just generally looking at symptomatic. And then I am a big advocate for asking the questions, the big major ones. Do you leak at any time? Do you have constipation? Are you struggling with any kind of vaginal pain or rectal pain, either in your daily activities or with intercourse? And do you have feelings of something falling out or heaviness or pressure?
That's good, quick and dirty. You should do your own quick and dirty assessment video.
It might have a bit of a different connotation in the pelvic floor, perhaps, quick and dirty assessment.
Maybe. Okay, I'm going to take the last question from Christopher Morrow. Do you find overlap between pelvic floor dysfunction and athletic pubalgia?
Yes, I do find quite a overlap between athletic pubalgia. Again, if the way I like to think about the pelvic floor and our abdominal wall and our diaphragm is that we're a big container pressure system. So if we're not getting the length tension relationship in the pelvic floor at the bottom of that canister, then we can start to see pressure differentials, muscle differentials in other ways at different manifestations. So absolutely, I do treat quite a bit of athletic pubalgia in my clients with their pelvic floor dysfunction. Not that I'm treating the pubalgia, but I see that as a manifestation for them as well.
Awesome. So I'm going to stop there. There's a couple more questions that will get sent